Good evening, fellow Canberrans and visitors. This is a special event of the Academy of the Social Sciences, and to welcome you properly and appropriately, I would like to invite the Academy's President, Professor Glenn Withers, to do so. Glenn?
Well, that was short, John. I thought we'd have an advertisement for the Academy, but thank you for that. I'm very pleased, of course, to also welcome you this evening. And also, could I welcome you through an acknowledgement of country as well, that we would like to acknowledge the Ngunnawal peoples, who are the traditional custodians of the land on which we're meeting, and pay respect to the elders of the Ngunnawal Nation, both past and present, and extend this respect to all Aboriginal and Torres Strait Islander peoples that are in attendance today. We're here for the Paul Bourke Public Lecture, the 2016 Paul Bourke Public Lecture, and I'm going to talk a little about the Academy and the award and its origins, and then hand over to the Dean of the ANU College of Arts and Social Sciences, who was also providing hosting for us today on this ANU land. And the Academy, of course, is the Academy of Social Sciences, one of the four learned academies, so called. And there are pretenders knocking on our door in areas like medicine and law, but the four long established learned academies, the Academy of Science, the Australian Academy of the Humanities, the Australian Academy of Technological Science and Engineering, and primus inter pares, the Academy of Social Sciences in Australia. Only the humanities would understand the Latin, but they're not. Some might be here tonight to challenge us on that front. We are especially important in the academic arena by our autonomy. We're non-governmental organisations, non-managerial organisations, some of us feel is important these days too, representing scholarship and the advancement of knowledge and research, in our case in the social sciences. And there's 546 scholars who are fellows of this particular academy. By one of my counts, I think the numbers are pretty even across the four academies, so that's about 2,000 fellows of academies. There's about 100,000 university personnel in Australia, so there's a fairly distinguished group, if I could put it that way, in the academies, and 560 odd in the Academy of Social Sciences who have been elected as fellows of the Academy because of their achievements in their research and scholarship. The achievement criteria does mean, though, sometimes that the appearance of the academies is a little bit greyish around the edges, and is also, as a product of history, a bit masculine. So we're doing our best to try and produce a little more diversity in the membership, and one way we're doing that, though, is by something like the Paul Bourke Lecture, which honours Paul Bourke, who was the director of the Academy of the School of Social Sciences here at ANU, the Research School of Social Sciences. But the point of the particular award and the lecture that goes with it is to give recognition to early career research, so that we get through the activities around this and in other areas an infusion of some younger spirit into the Academy of Social Science activities. Awarded by the Academy, it honours Australians in the early part of their career who have achieved excellence in scholarship in one or more fields of the social sciences. We publish a copy of the lecture, and I should warn you to be on your best behaviour because we are recording the lecture tonight, so please be aware that that is the case, and we take it that you're agreeable to that. And in pursuing these sorts of matters, I should put that in the context of the other things we do in terms of promoting excellence in the social sciences, providing evidence-based policy advice from time to time, most recently through a set of projects called Securing Australia's Future, where we worked with the other academies to produce a series of 13 reports for the government that were distinctively interdisciplinary as well as policy related, so that the academies cooperating was itself quite an achievement. Doing so in an interdisciplinary manner, given our disciplinary traditions of scholarship, was also a significant step, I think. Responding to many people, like heads of Prime Minister and Cabinet, who make lectures when they step down and say, well, we weren't able to work so well with academia as we'd like to, because they always present their advice in a scholarly, discipline-oriented manner, and we deal with holistic problems, and we wished we got more holistic advice from the academies. So we took these complaints seriously and set up a set of projects that looked at those, and the first of the projects was indeed managed by the Academy of Social Sciences on Australia's comparative advantage. It was launched late last year by one Professor John Hewson, now of the ANU, and the Chief Scientist, the incoming Chief Scientist, Dr. Alan Finkel. We also work in national collaboration, most recently with the Chinese Academy of Social Sciences and the Shanghai Academy of Social Sciences, which are separate bodies, and they operate in very interesting ways that are a little different from the way our academies operate. I think it's hard to quite describe them as autonomous in the same way ours are. They do receive government funding and are often involved directly in governmental work, consultancy style work. We're also seeking to raise public awareness of the role and value of the social sciences, and again, most recently, and I hope people have been aware of this, the whole dispute over CSIRO changes. While most of it was for the climate scientists and the Academy of Science and technological sciences areas, a significant number of social scientists worked at CSIRO and have been affected by the changes, so that the academies again got together and are seeking to undertake a stocktake of the capabilities in this country and what is needed to deal with social, scientific, environmental and cultural and other issues in grappling with climate change, so that we are seeking to offer something that will inform these sorts of debates and what we need to manage these issues through evidence-based analysis in a better way, rather than just advocate and say, hold your hand out for more money. We thought we could contribute something more than that. Likewise, we're equally concerned about the impact of the so-called efficiency dividend on the national cultural institutions, the impact on small agencies of which in Australia's arrangements are places like the National Portrait Gallery and the ABS, small agencies like that, crucial to areas like the social sciences and our colleagues in the humanities especially. We're very concerned to see that very blunt instrument of an efficiency dividend made less blunt by improvements in public management that we have offered to assist in looking to other tools to help deal with these sorts of economy issues, but in ways that don't undermine the basic soft infrastructure that's needed in areas like social sciences and humanities. So that's by way of an introduction of the broad things we try and do. We're trying to reinvigorate that with young social scientists joining their experienced colleagues. And to that end, I'd particularly want now to mention, of course, that Philip Batterham has been awarded that Paul Bourke Award and is giving us the lecture on that subject tonight. I believe his father's here tonight, so we'd like to welcome him as well. But also I'd particularly like to welcome Paul Pickering, who is the Dean of the College of Arts and Social Sciences here at ANU, so that he can introduce our speaker. Thank you.
Good evening, colleagues and friends. I'm representing the Vice-Chancellor here tonight, Professor Brian Schmidt, who is unable to attend. I'm delighted to have that opportunity, not only because it gives me an opportunity to introduce an outstanding young scholar to an august to an august audience of a very important institution. But it also gives me the opportunity to say something about Paul Bourke. I knew Paul and worked with him when I first came to ANU. Feels like the middle of last century, but it was 1999. Paul was the head of the history program here, and previously had been director of the Research School of Social Sciences, and I think at that time was president of the Academy. I said to Tom Griffiths today that I was doing this tonight and that I could say something about Paul. He said, yeah, Paul was scary. And I think that's probably true. I remember when I first came to ANU, he said, oh, I'm not really happy about this. And I was sort of timid, young postdoc. And he said, up until now, when someone shouted, Paul, along the corridor, I knew who they meant. And so now there's a confusion. And I remember later on when I'd done my first overseas research trip, I'd worked in the public sector for a while, and so I did an itemised itinerary of where I'd been, and I did a spreadsheet of all my expenses, and I clipped all the receipts to the back of this thing. And I was walking along the corridor, and Paul jumped out of the office and says, hey, what's this? I said, it's my reconciliation of my grant. And he said, well, now everyone's got to do them like this. Paul was absolutely fantastic to the early career researchers. Very often he'd knock on the door and say, do you want to come and have a cup of coffee? Or if you were going to morning tea, he'd sort of grab you and take you to one of the small tables in the famous Coombs tea room. Just have a chat, see how you were going. He once said to me, and I'm sure he was wrong, that I had a CV that was better than his when he was a senior lecturer. And he was trying to encourage me through one of those difficult times when you're on a time-limited fellowship. And he really pushed me to put in a Queen Elizabeth Fellowship application, which subsequently set up my career here at ANU. And so I know from my personal engagement with Paul how delighted he would be to have his name associated with a lecture for early career researchers. He was passionate about developing the next generation of leaders in the social sciences. And this is exactly what we're doing tonight when we're going to listen to a stellar early career researcher in Philip Batterham. And when you're a dean, they give you sort of briefing notes for this sort of thing. And I was reading through them, and it says that Philip has published 85 peer-reviewed papers, including more than 60 since getting his PhD in 2011. Now, I thought that's got to be a typo. That's far too many refereed papers. And then I thought, well, maybe for a historian they're short. But that is a lot of work, and it's part of a stellar CV that he has accumulated. He's been the recipient of considerable National Health and Medical Research Council funding, including an early career fellowship in 2011 and a career development fellowship in 2014. He's the chief investigator for the National Health and Medical Research Council Centre for Research Excellence in Suicide Prevention and for 5 National Health and Medical Research Council projects. In 2015, he was awarded the Commonwealth Health Minister's Award for Excellence in Health and Medical Research. He's one of a whole number of jewels in the crown at ANU, the sort of national leaders that we're hoping to produce, and the sort of national leaders in the social sciences, which I know the Academy is so keen to nurture. And so it gives me the very greatest pleasure to welcome Philip to the podium. Please join me in welcoming him.
Thank you for that very generous introduction, and thank you all for coming along tonight on this fairly wild evening in Canberra weather. So thanks for coming along. I'm giving the Paul Bourke lecture, and it's a great honour for me to be giving this lecture to you tonight in honour of Professor Paul Bourke. So my topic is novel directions in population mental health research. I'm based at the National Institute for Mental Health Research at the Research School of Population Health, that's a mouthful, at the ANU. And I'm going to be talking about a range of different research that I've been doing over the past few years in collaboration with others. So just a brief outline of what I'm going to talk about in the next half hour or so. Firstly, I'm going to talk a bit about what mental health is. And then I'm going to talk a bit about new approaches to assessing mental health, which has been the focus of my research the past few years. Then I'm going to talk about new approaches to reducing symptoms of mental health problems, and finish up talking a bit about population approaches to preventing suicide, with one particular example from my research as well. So because I'm going to be talking about suicide tonight, I'm not going to be going to any level of detail, but I think it's important to remind people that if they do have concerns about their mental health or that of others, they should contact one of these services. So firstly, what is mental health? Most people think of mental health as just the absence of a mental disorder, but it's more than that. The World Health Organization defines it as a dimensional state ranging from wellness to illness, or from health to distress. So it's more of a continuum than just presence or absence of a mental health problem. When I talk about mental disorder, generally it's basically the same thing as talking about mental illness or mental ill health or mental health problems. There's slightly different definitions for those, but they're often used interchangeably. There's a range of different factors that influence mental health. It's not as simple as some other physical health conditions, but there's a whole constellation of risk factors that go into whether somebody is having a mental health problem. And these include behavioural or psychological factors, such as coping mechanisms, things like that, personality, other sorts of behavioural and psychological factors. There's a strong genetic component to many mental health problems, as well as neurobiological mechanisms underlying these. Physical health has a strong interplay with mental health as well, so physical health problems are often associated with comorbid mental health problems. The environment that somebody lives in and situational or event-based risk factors also influence mental health, so relationship breakdown, workplace problems, things like that, unemployment, events like that can influence mental health as well. So in Australia, about 20% of Australian adults meet criteria for one or more mental disorders in any 1 year period. That's based on the 2007 National Survey. So this equates to about 3.2 million Australian adults, so very big burden of disease. The highest rates of disorder are for anxiety disorders. Over 14% of adults meet criteria for an anxiety disorder in any 1 year, compared to just over 6% for a mood disorder, typically for depression, and just over 5% for alcohol and or substance use disorders. There are other disorders as well which are less common and that aren't covered by this survey, but these are the areas where most of my research is devoted to, and these are the most common types of mental health problems that people experience. So mental health problems have a massive burden in terms of burden of disease on the impact on society, primarily from the increased disability due to mental health problems. People are unable to work or carry out their normal functions because of mental health problems quite often. You can see there's less impact from deaths due to mental disorders, but overall the disability, proportion of disability attributable to mental health problems is significant and greater than any other kind of domain of health. So approximately 24% of the disability burden in Australia is accounted for by mental disorders, and 1.8% of deaths, accounting for, when you put these together and weigh them together, that counts for just over 13% of the total total disease burden. Just by comparison, a little political plug here, we found that in 2011 that mental health received about 9.5% of total NHMRC funding, so way less than what the disease burden is. And we just rerun these analyses on last year's data, and the figure's around 8.5% for last year. So we're kind of the poor cousin of physical health problems in terms of funding, but we tend to punch above our weight in terms of impact. So another way of looking at burden of disease is looking at the cost impact on the economy. So these are fairly old statistics, but the latest estimate on the cost of mental disorders on the healthcare system is around $4 billion, and in terms of lost work productivity is almost $6 billion. These have probably gone up quite considerably since these estimates were made. In addition, suicide is the leading cause of death for 15 to 44-year-old Australians. So even though there's not a large number of deaths that occur due to mental disorders, it tends to be in the younger age group. So there's greater loss of years of life lost due to suicide than many other conditions. So in this talk, I'm going to keep coming back to this picture, which is probably familiar to those of you who work in population health, and you're probably sick of seeing it. But just to give some guidance as to where I'm working on the spectrum of care and providing interventions and programs. This is kind of a useful heuristic to think about that. So interventions and programs can go anywhere from promotion level on the far left, which is like things that are done within the community to reduce the impact of disease and disability. Or we can come from a prevention framework, and that can come in the form of either universal programs, which are targeted to everybody in the community, or selective programs, which are targeted to people with risk factors for a certain mental health problem. Or we can do indicated prevention programs, which are targeted at those people who have symptoms of a mental health problem, but don't yet meet criteria for that mental health problem. Then in terms of treatment, first we need to identify people who do need treatment. So that's where case identification comes into it, and assessment of mental health problems. But that's also important for prevention as well, because if you want to identify people at risk of having a mental disorder, you need to assess them as well. And then treatments for mental health problems. These are typically psychotherapy, often cognitive behavioural therapy or other approaches to psychotherapy, or pharmaceutical therapy as well. Then in terms of recovery, there's a range of different programs that can assist people in adhering to long-term treatment plans and to aftercare. So the first of the three areas I'm going to discuss, three areas of research I'm going to discuss, is some new approaches that we're applying to assessing mental health in the population. So this comes into that little quadrant of or that little section of the continuum of care, case identification. So traditionally in assessing mental health in the population, we use standardised scales which are validated for use in that population. And these are generally designed around expert consensus of what the important symptoms are, which then neglects the consumer experience of what it's like to experience a mental health problem. Everybody typically gets the same set of questions or items to assess their mental health, and each item is given equal weighting. And most of these scales are designed to assess either criterion, whether somebody meets criteria for a mental health problem or not, or designed to assess the continuum of mental health. There are very few that are designed to do both of those things at the same time. So just to make it a bit more concrete, here's an example of a scale. This is a PHQ-9. It's quite a good scale for assessing depression. And it uses the 9 kind of most common symptoms of depression that are aligned with the Diagnostic and Statistical Manual, which defines what the depressive disorder looks like. So people answer these 9 questions. It can be self-rated on the scale provided. It's cutting off on the screen. Okay, so that last one is nearly every day. So you get a score from 0 to 27 based on your responses to those items, and using that you can get a cutoff for where depression is likely to be. Here's another scale that I'm not so keen on. This is a panic disorder severity scale, self-report. So these are the first 1.5 items from that scale, and that's a 7-item scale. So using this as a screener in the population is not particularly feasible, because it'll take about 10 minutes to administer this sort of scale. So we're looking at creating more brief and precise screeners to assess mental health in the population that don't require all this reading to go through this sort of scale. So this new approach is designed around data. So the general aim of it is to create item banks that can then be used for screening purposes. So these item banks are based on both consumer experience and expert knowledge. We get feedback from both groups. The items that we end up with can be tailored to the individual and can be weighted based on norms. So it's much more flexible than traditional ways of assessing mental health. And these types of scales can be used to assess both criterion and continuum. So the basic idea, let's think about some fish for a minute. So if this is our pool of items that we're going to choose items from for our item bank, we've got 12 items here, but typically you'd have dozens or even hundreds of items to choose from. So each item here, each fish here represents a question that we might use to assess, for example, depression. And you can see that some of these items look pretty much the same. So item 2 might be, I experience severe depression, and item 9 might be, I experience extreme depression. So if they're basically the same, then we can take out the duplicates like that. And there are a few small items, there's a few small fish here which don't really account for much of the experience of depression. So they're not really relevant to consumers or to experts, so we might take those out. And then there's a dodgy looking fish at the top who's kind of floating on the surface. That might be an ambiguously worded item or an item that's conditional on experiencing a certain type of experience. So we might want to take that one out as well. So then we're left with our item bank of 7 items. In reality, it's many more items that we can use to then inform the creation of new screeners. So we did this, so once you've got your items, you can then measure them. So what sort of level of severity does each item measure, and how accurately does it discriminate the construct of interest? So how well does it discriminate depression, for example? So we've done this for a range of different mental health problems. Just reiterating, we take a large pool of items, we cut out items based on overlap, ambiguity, consumer and expert ratings of how relevant they are. And then we've tested them and calibrated these items in a large community-based sample of more than 3,000 people that were collected last year. And from these, we can then develop screeners and scales from the item bank that can really efficiently and precisely assess whether somebody might be having problems with a certain types of mental health symptoms. So here's the process. We started with thousands of references and many scales, and for each of these different areas of mental health, so adult attention deficit hyperactivity disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress, psychosis, social anxiety, drug use and suicidality. So for each of those, we found items that already exist and then went through this process of winnowing them down based on items that were taking out items that were duplicates or ambiguous, conditional, non-specific or time-based. And then we got ratings at on the second last row from consumers and experts saying how relevant and appropriate they thought these items were, to get down to these item pools of about 45 up to 79 items for each one. So this was a fairly large undertaking, part of a large NHMRC project. And I see one of the research assistants for that project is sitting up the back here. So she did most of that work, fortunately not me. Thanks, Jackie. So we had each of these measures for each of these disorders. We had these new item pools that we created through this feedback process, and existing item banks for depression, generalised anxiety, anger, aggression and alcohol use. So we tested these, we calibrated them in this large population-based sample, tested them against existing screeners and against DSM-5 criteria for each of these disorders to create new screeners and item banks. So here's an example. This is the suicidality candidate items for the item. So this is the item pool that we started with for suicidality. So we gave all of these to consumers and to experts to narrow down to these items, which is the item pool that we then tested in the sample of over 3,000 Australian adults. And from that, we found the items that best discriminated suicidality in that sample, and we got the final calibrated item bank of 23 items. So a lot of cutting down there to just the best items. And this is a graph of how they look. It's a bit chunky on here, but on the x-axis, the horizontal axis, we have severity. So each of these curves represents one item. Each item measures a different level of severity. So like I said, items that might be measuring a suicide attempts would be at the more severe end of the spectrum, whereas those items assessing suicidal ideation would be at the less severe end of the spectrum, with 0 being the population mean on that scale. On the y-axis, the vertical axis, we have the amount of information that each of those provides, which is kind of a measure of precision, how precise it is across that severity spectrum. So using these graphs, we can work out which items are the best ones for assessing suicidality. And we can see there's 4 representative items that kind of summarise that entire kind of group of items. They're very precise and they cover the entire kind of severity spectrum of all the items. So that's how we can winnow out another subset of items that we can use for screening. So these are those 4 items that we can use as a suicide screener. And it turns out that responses on this is just as accurate as a much longer screener that we compared it to both in assessing the spectrum of suicidality and in predicting whether somebody's going to have a suicide attempt within the next 3 months. We can also use this process to create what's called adaptive screeners, where either the response to one item determines which item comes next, or determines whether somebody stops answering questions. So it makes it a much more efficient process. And using this sort of approach, we can get down to a mean of just 2 items. So asking somebody 2 items can assess their suicidality much more rapidly. And again, this is just as accurate, if not more accurate, than using a standard set of questions for everybody. We can also use this approach for creating general distress screeners, so looking across different disorders and which are the symptoms that might best distinguish whether somebody might have some sort of mental health problem. So you can see there's just 5 items there, really quick to assess responses on this scale. And the standard for assessing psychological distress or general distress is the K6 or K10, which are 6 or 10 items. So we wanted to create something that was a bit more accurate than the K6 and K10. And it turns out that these 6 items are actually quite accurate in doing so. Here's a comparison with the kind of existing standard screener for assessing general distress, the K6. And you can see that the new measure, the DQ5 or Distress Questionnaire 5, was more sensitive and specific in identifying any disorder compared to the K6, this industry standard sort of screener. It was also more sensitive in identifying most of the disorders that we tested. So summarising the work that I've just discussed in creating better assessments for mental health. So there's this large, lengthy process of developing large item pools for various mental health problems. And from this, we create item banks using data from large community-based surveys. And this leads to, ultimately, to cutting down from thousands of items down to just a few items to create brief and accurate and flexible approaches to measuring mental health problems and for screening for mental disorders. So now I'm going to move on to a slightly different area, but it's all related somehow, to approaches to reducing symptoms of mental health problems in the community. I'm going to be talking specifically about online programs, which are typically based on CBT and provide therapy through the internet. So again, going back to this continuum of care, these sorts of online programs can work on many of these areas, from prevention to treatment, and they're highly effective for treating and preventing many mental health problems. The example I'm going to give today is of a program that's designed as an indicated prevention program, so targeting people who have some symptoms but don't have a disorder yet, but also as a treatment for those people who have mild to moderate symptoms or disorder. So there's a number of barriers to people receiving appropriate health care, and that's particularly the case for mental health care. Firstly, the availability of services, the hours it takes to go to an appointment and to get to an appointment, and the distance that people have to travel to do this, particularly in rural areas where people are lucky to have access to a GP within 100 kilometres, let alone a clinical psychologist. Another barrier is the cost of services. For people vulnerable at disadvantaged groups, it's often can't afford the $100 or $200 it costs to see a psychologist for an hour. Fidelity of treatment is important. Clinicians don't always provide evidence-based programs, as well as appropriate treatment that's appropriate to an individual's needs, so customising the treatment to the needs of the individuals and their preferences. It's also difficult to scale up existing services. There's only so many psychologists to go around in Australia, and only so much, and there's more need than there is availability of health services. So we need to find other ways to scale up existing mental health services and reach that broad cross-section of the community, including vulnerable and underserved populations. So the alternative option is, or adjunctive option, is e-mental health programs, which are always available. They're available 24/7. They're often free or relatively inexpensive, They provide consistent delivery of cognitive behavioural therapy and other types of therapy online. And they can be tailored to needs. There hasn't been much tailoring of online services, but I'm going to talk about a new program that does use tailoring. And they can scale up, obviously. They can reach anybody who has an internet connection. So we know that there's been a lot of research on e-mental health programs over the last 15 years or so since they emerged with the likes of Mood Gym that was developed here at the ANU. And we know that they're highly effective for both treatment and prevention uses. For example, for depression, there have been 9 meta-analyses of randomised controlled trials. There's been dozens of randomised controlled trials. And generally, there's fairly large, moderate to large effect sizes, so fairly robust effects of these sorts of online treatments. Similarly, for anxiety, there's large effect sizes of online programs for treating anxiety. And for alcohol and substance use, slightly smaller, but still significant effects of online treatment programs for alcohol and substance use. And there's also emerging evidence that for treating suicidal ideation, that e-mental health programs can be effective there as well. So we know that these sorts of programs work, but there's 2 questions that haven't really been addressed very well by the literature. Firstly, how can we increase the use of evidence-based e-mental health programs? So how can we implement them in real-life settings? And the other question is, how can we make them work better? So I'm not going to talk about the first question today, except to point you to this document that's on the NHMRC website, which I co-authored, which is a translation of e-mental health services for depression, and sets forward a number of ways that policy and practice can take these up and have them available to consumers and to clinicians. The other question as to how we can make e-mental health programs work better, I think comes down a lot to increased engagement. So if a program is not engaging, not interesting, then people aren't going to complete it. So you'll get low adherence and the outcomes are going to be diminished. So there's a number of ways to increase engagement to these programs. Firstly, you could make them faster, just focus on the core therapeutic strategies, so much briefer, rather than doing lots of 50-minute sessions as you would in a face-to-face setting. Make it faster and just focus on the core strategies. Making it more relevant is another way to increase engagement. And I'm going to be talking about this program in a minute called Fit Mind Kit that tailors the content of the intervention to the individual. Another way to make it more engaging is to make it more appealing using videos rather than text, making it more like a game, online video game, which appeals to certain segments of society, and making it more interactive generally. So in terms of tailoring, to do effective tailoring automatically, we need precise and rapid screening and assessment, which comes back to the first topic of my talk, that we need to have these tools available to be able to assess whether people need, what sort of resources people need. Then you also need a range of different modules addressing different mental health problems and data on which of these modules works best for which people. And then we can also account for individual preferences. So here's the example I'm going to give, which is called Fit Mind Kit, the program. It was developed by myself in collaboration with other colleagues at my centre. And you can see that there's 5 different characters, and each of those tells a different story about mental health problems. So the tailoring works as follows. So there's different kind of overlaps between all of these disorders are highly comorbid, so people with anxiety disorders often tend to also have mood disorders and or alcohol or substance use disorders and or suicidal ideation. So depending on the pattern of symptoms that somebody has, they get a different pathway through the intervention that's tailored to their symptoms. So you can see there's 11 different pathways that an individual might get when they come into the program, and there's 18 different modules that they can receive. So depending on which pathway they're in, they'll get a different combination of 10 out of those 18 different modules. So that's how the tailoring works. If I can get this to work, I'm going to give you a 2-minute example of one of the modules of Fit Mind Kit, just to give you an idea of how it works. I'm just going to have to tilt the microphone down so you can hear it, and it'll give me a chance to rest my voice as well, which is nice.
Hi, I'm Lisa. Welcome back to Fit Mind Kit. You've already heard in the first session about some mental health problems that people experience. You also heard that most of us sought professional help, even if we were reluctant or unsure of what to expect at first. Today I'm going to talk to you about how to get help when you're having a problem. There are different people out there that can help, all with pros and cons. Although family and friends can't assess or treat mental health problems, I found it really helpful to discuss problems I was having with my close friends and my sister. They made me feel like I wasn't alone. A lot of people find that parents, partners, and other family and friends are an important source of support, so these guys are always a good start. But in the end, mental health problems are a health problem, so it's important to get help from a health professional. Sometimes it's easier to talk to someone who is a bit removed from your situation too, knowing that what you say won't affect them too much. Going to my GP was an important step in helping me get better, and they can help you to get treatment for all types of mental health problems. It might feel a bit awkward at first, as you don't know what to say or where to start. I was pretty nervous before my appointment, so I prepared by writing down a list of what I was feeling and writing a little script or plan to help me express what was bothering me. To my surprise, my GP was really great and told me that she sees lots of people with similar problems. The more people I've told, the more I've realised that struggling with stuff is actually pretty normal. My GP assessed my mental health, provided me with resources, set me up a treatment plan, and referred me to a clinical psychologist. It was a big help not having to find one on my own. This was a big step in starting my treatment. Before I started seeing my psychologist, I wasn't sure of the differences between psychologists and psychiatrists. Like a lot of my friends, I thought they basically did the same thing, but that's not true. Psychologists can provide a range of talking therapies. Many psychologists use cognitive behavioural therapy, which helps you to understand how your thoughts directly influence your feelings and behaviours, and provides you with skills to challenge negative or unhelpful thoughts. Cognitive behavioural therapy can be very helpful for reducing symptoms of depression and anxiety. Other types of therapy can be used to manage alcohol or drug problems and suicidal thoughts. Psychiatrists, on the other hand, can also provide talking therapies, but they are also able to prescribe medication that can help change the chemical imbalances that occur in people experiencing depression or anxiety. There are many effective medications to reduce symptoms of depression and anxiety. There are also other health professionals who can help people who are having mental health problems. Community-based programs, including drug and alcohol programs, can help support people who are trying to recover. Social workers and other health workers can help people with mental health problems improve other areas of their life, for example, by helping them find a job or a place to live. Online self-help programs can also be beneficial. There is a wide range of internet resources that can provide information and help people develop skills to reduce their symptoms. Scroll down to take a look at today's activity. Make a map of the people who support you and think about where you could go to get help if you are having problems with your mental health. See you next time.
So as you can see, that's a fairly low resource intervention. We didn't have a whole lot of money for creating a fancy graphics and stuff, but I think we did enough to make it a bit more entertaining than reading a bunch of text. So that's just one of the modules, one of the 18 modules that's available through this program. And we're currently conducting a randomised controlled trial of this program in young adults aged 18 to 25. And we're comparing these tailored modules versus a static set of modules, so that people just get the same 10 modules in the comparison conditions, and then comparing that to a attention and control condition, which is just giving people information about physical health problems, which is unrelated to mental health problems. We've also got a proposal into NHMRC to test different implementation pathways to see what's the best way to get uptake of these types of programs in the community. So the final area I'd like to talk about tonight is about population approaches to preventing suicide. And I'm going to give one example of some of our research in this area. There's a number of strategies that can have been shown to be somewhat effective in reducing suicide deaths. These include psychoeducation, increasing public awareness of suicide through education, restricting means of access to lethal methods, more appropriate reporting in the media, gatekeeper training for training those people who come across people who are likely to be at risk of suicide, better screening and detection, which I've talked about already, training health professionals in suicide prevention, increasing uptake of psychotherapy and appropriate antidepressant use, and follow-up care for people who have attempted suicide or are at risk of suicide. So this, again, goes through that continuum from promotion down to treatment and management. So I'm just going to talk about one example tonight that focuses on public awareness and public education around suicide prevention. So this is in that far quadrant or far sector of the continuum. So we know that the majority of people who die by suicide actually have no contact with their primary care doctor in the month before their suicide, and 2/3 have no contact at all with mental health services in the year before suicide as well. So the question arises how to increase rates of professional help seeking in this vulnerable group. One factor which has been known to be associated with help seeking in mental health more broadly is stigma, which basically means negative attitudes towards people who die by suicide or people with mental illness, depending on the focus. This can take three forms that are studied quite widely. Personal, which is an individual's own attitudes about people who die by suicide. Perceived stigma, which is what I think other people think about people who die by suicide, what I perceive. And self-stigma, so people who are suicidal, how that reflects on themselves and how their symptoms reflect on themselves as an individual. And this can lead to discrimination, and like I said, it can also reduce professional help seeking. So it's been discussed a lot in the literature how stigma might play a negative role on people who are suicidal, but there hasn't been a whole lot of systematic, rigorous measurement of the stigma of suicide in the community. So we created a new scale, me and my colleagues created a new scale called the Stigma of Suicide scale, which has 16 descriptors of a person who has died by suicide, rated on a scale from strongly agree to strongly disagree. And we've validated it in a number of different samples, including university-based samples and community samples. And I just read a paper that came out today that they've validated it in Turkey as well, so they've translated it into other languages and found that it has the same structure in other countries as well, which is nice to see. So here's the short form of the SOS. You can see there's items assessing stigma. We've got 8 items there because we wanted to focus on stigma, as well as descriptors associated with isolation. So we tend to find that people endorse isolation items, as these are quite typical of people who die by suicide, being isolated and disconnected. There's also a glorification item where people rate suicidal people as being brave or dedicated. This tends to be rated a little bit higher than isolation, a little bit lower than isolation, but not as low as the stigma item. So people are generally not particularly stigmatising, but there are some items on there that are endorsed quite highly. So the other kind of correlate of help seeking that we're aware of in the mental health literature is literacy of suicide. So literacy is public knowledge, and that incorporates a range of different areas of knowledge, including knowledge about risk factors, knowledge about the causes of mental health problems or suicide, treatment and prevention, and that it is preventable, and the signs or symptoms that somebody is having problems. So again, there hasn't been a lot of research on this in the area of suicide, so we created a new scale called the LOSS, testing various true-false items. So there's 12 different items, and the total score is the number of correct responses, and they cover all the different areas of suicide literacy. So here's the 12, this is the short form of the LOSS, showing the different items and which categories they fall into. The items in yellow are false based on the literature, and the items in white are true. So depending on how many items people get correct on this, it gives us a literacy score, and we can look at the relationship between an individual's literacy and stigma and whether they're likely to seek help or not. So we've found in our research that that higher literacy, so more knowledge about suicide prevention, is associated with more positive attitudes towards help seeking, which is what you would expect. Conversely, less stigma is also associated with better attitudes towards help seeking. We've also found that less stigma is associated with higher intentions to seek help from a mental health professional, whereas high literacy is associated with more likelihood of seeking help from family or friends, and lower literacy is, higher literacy is also associated with lower intentions of not seeking any help. So that's a good thing, that the more knowledge you have, the less likely you are to not seek help. There's a few double negatives in there, I think I got that right. We can also go into which items are associated with help-seeking outcomes most closely. So there's a bit more nuance in this, and this is where we can inform public health campaigns. So generally they're in the direction that you'd expect, that people who get the answers correct to each of these items tend to have more positive attitudes or intentions towards seeking help. But it's not always the case. So with the second one, the people who get that one wrong actually have greater intentions of seeking help. So if people think that everybody who kills themselves is depressed or has a mental health problem, they're actually more likely to go and seek help for that problem. So when you're creating a public health campaign, you wouldn't want to talk about how not everybody who kills themselves is depressed, because this might actually lead to unintended negative consequences of these sorts of programs. Again, we can do the same thing with the stigma items as well, but we generally find that they're in the expected direction, in that people who are less stigmatising are more likely to go and seek help. So just to summarise that, so high suicide stigma plus low suicide literacy leads to both poorer attitudes to help seeking and lower intentions of seeking help. So these findings can be used to target suicide prevention campaigns, both to the facts and the attitudes that are most likely to increase help seeking. We've also found, I didn't show you these results, that there's certain groups which are more likely to be stigmatising or have lower literacy, and these include males and culturally diverse groups. We're also working on longitudinal research and a number of trials, testing whether we can reduce stigma and increase knowledge, and whether that has a consequent effect on help-seeking outcomes. So we've done a small pilot trial which found limited effects of messaging for suicide, but it had effects on anxiety and depression. One of my PhD students who's here tonight is currently conducting a larger cross-national trial in both Australian and Chinese students, which is a large undertaking, to see whether we can impact on these sorts of outcomes in students. So that's just one of the areas of suicide prevention research that I'm currently conducting. We're working in a range of other projects collaboratively with collaborators here at ANU and with the CRE in suicide prevention, which is based at the Black Dog Institute. One of these is to look at the systems approach to suicide prevention. So this is seeing whether, I showed you the list of all these different interventions that might reduce the suicide rate. So if we try and implement all of these things at one time in one location, can we actually have an impact on suicide deaths? So we're going to be rolling that out in the next year or two, and that'll be an exciting project. There's another PhD student I'm working with who's looking at interventions after a relationship breakdown, which is a time also for heightened risk of suicidal thoughts and behaviours. I'm also interested in testing theoretical models of suicidal behaviour, particularly Thomas Joiner's model of why people, interpersonal psychological model of why people kill themselves. Like I said, we're also testing suicide prevention programs in the online space, and this year we've started a peer connectedness trial in schools, so seeing whether if we can link students to trusted adults, we can reduce their risk for suicide and increase their likelihood of help seeking if they are going through a difficult time. So just about reached the end. Time for a quick wrap up. So I've shown you this slide about 20 times now. So I've covered most of the spectrum. I haven't done a lot in recovery, but there are other researchers at my centre working in that space as well. So you can see that there's these different components of research that can inform across the spectrum of care and interventions in mental health. So there's a range of new approaches which I think there's an exciting future in population mental health. And here at the ANU we're doing all sorts of interesting, I think, and exciting research around mental health and population mental health. So firstly I presented about better ways to measure mental health, and then more tailored and accessible interventions to make sure people get the help they need. And then I finally presented on better understanding of the help-seeking process, and all with the general aim of making sure that the right care is available for the individual at the right time when they need it. So finally, I'd like to acknowledge the Academy of Social Sciences for the award and for the opportunity to present this evening. Thanks to the ANU, for NHMRC and my funding bodies, to my colleagues, collaborators, family and friends, some of whom are here tonight, particularly Helen Christensen and Alison Kalia, who have been my collaborators in many of these projects that I've discussed tonight, as well as Helen Christensen and Karen Anstey for nominating me for the Bourke Award.